Welcome to A&T Respiratory Lectures. This lecture, Sleep Medicine Challenges and New Frontiers, will be brought to you by Albert Ure, who's the co-owner of A&T Respiratory Lectures.
Now, during this lecture, we're going to focus on the following learning objectives. We'll start off by reviewing the importance of research in sleep medicine. We'll summarize key concepts in medical research. So more or less, if you were to open up most any clinical research textbook, there's certain terminology and concepts that you would encounter, irrespective of whether it's sleep medicine, pulmonology in general, cardiology, etc. So we'll talk about those topics because they'll relate to the actual discussion of the research itself, and it'll better enable you to be able to see the contextual framework for those research studies. We'll describe strategies for searching the literature, identify some more recent research which has helped shape sleep medicine. We'll look at the research related to physiology, that to do with diagnostics, the various treatment modalities. So we'll certainly include positive airway pressure as the mainstay, but there's some other developments that have enabled the arsenal for treatment modalities to be expanded. We'll also look at adherence. And really what we're talking about there is adherence to positive airway pressure. So it's still the mainstay of our treatment approach to obstructive sleep apnea, but adherence, getting patients to initially adhere to that treatment protocol and to stay where they're actually working that program and complying with the actual positive airway pressure every night is a challenge. It was a challenge 20 or 30 years ago. It's still a challenge today. So we'll discuss the extent of that challenge and some of the approaches to overcoming them. I also included a couple studies related to cost effectiveness. So really the cost effectiveness of one therapy versus another. We'll wind things down by describing where more work needs to be done. And probably most importantly, I'll be providing you with additional resources for those of you who want to drill down and learn more about these topics. Let's examine the importance of research to sleep medicine. And some of these concepts would really be applied or could be applied to clinical research in general. So research directs how and why we practice medicine in the way we do, and in particular, why we practice sleep medicine in the ways in which we do. Research also helps ensure a safer and effective practice. It helps build a foundation for future practice. It's also important in evaluating basic scientific reports, which is now deemed a core competency for clinicians, certainly for educators, and more recently for administrators. Without research and the ability to assess the literature, stagnation occurs, and even worse than that, it can actually render some of the practices that were thought to be the mainstays but are now refuted by the more recent research to be continued. So we can actually be continuing to use obsolete, if you will, techniques unless we continue to conduct research and let that research dictate practice. So let's ground our discussion on research by first looking at excerpts from a widely accepted definition of research. So research involves investigation or experimentation aimed at discovery and interpretation of facts, revision or confirmation of accepted theories and practices, and practical application of new or revised theories and laws. So the key points: it's investigative. It involves discovery and interpretation, and can also simply support our current practices or basically come up with new ways of practicing in sleep medicine. In addition to the definition of research, there's also other key terminology that if you were to pick up a research article related to sleep medicine, related to pulmonology, related to some other field within medicine, you would actually often see this terminology appear. The first of which is the hypothesis, which is the statement that's actually being tested. So initially, when they were investigating positive airway pressure, so CPAP and BiPAP, it was, that CPAP or BiPAP can be effective in effectively treating obstructive sleep apnea. We now know that to be the case, but 30 years ago, we actually did not. We will look at definitions of subjects or participants. Those are the individuals that are actually being studied. The intervention or the clinical maneuver being applied, in that example I just gave you, would be positive airway pressure. Blinding, you can have single blinding or double blinding. It's the hiding of, basically if subjects are receiving the intervention or a placebo. So in certain cases for positive airway pressure, they're actually receiving positive airway pressure. In some cases, that's compared to a mask, but it may simply be a simple mask connected to room air. And for those individuals who are naive, if you will, on CPAP, who really don't know what it is, they might be thinking they're getting an effective therapy. The control group versus the experimental group. The control group would be the traditional treatment, and the experimental group is the intervention that's actually being tested. So for instance, positive airway pressure 30, 40 years ago versus some other intervention. The p-value, which you'll often see also in research protocols and articles, is the likelihood that a particular finding is due to chance. Now, there's always that possibility in research. Research is explorative and it's also not perfect. Medicine is not perfect, but it's widely accepted if the p-value is 0.05, which is a 5%, or less, if it's let's say 0.04321, that would mean that it's a 5, 4, 3, or 2% chance that it's by chance that is the result. And that is an accepted, if you will, margin of error. Another way of putting it is we're at least 95% sure that the finding is due to the intervention, to the intervention or interventions that are being tested versus by chance. Now let's quickly examine the types of quantitative research. Say quantitative research. Quantitative research accounts for, well over 90% of the research that's done. Qualitative research is more like, is more like an interview with a very limited number of, if you will, experts, that sort of thing. That's qualitative. Okay, qualitative. It represents the minority. However, this particular presentation is really geared not towards qualitative, but towards quantitative. And the types of quantitative research are as follows. You have what's called systematic reviews and meta-analysis, where you combine the results of many well-done randomized control trials, RCTs. I'll define that next. So they take the results of, they take a look at, they actually review the literature, they identify potentially related, research studies, and they'll eliminate the weaker ones, and they combine the results of the stronger ones. Randomized controlled trials would be a single trial using a control and an experimental group. Blinding, I mentioned before, is neither the control subjects or the experimental subjects know whether or not they're getting the intervention. If it's double-blinded, nor do the researchers. So the subjects nor the researchers know. That would be known as double-blinded. Cohort studies are kind of in the middle of the pack, where you follow a population over many, many years. There is what's called the Framingham Heart Cohort Study, which is where they actually followed a population in Framingham, Massachusetts for decades. They looked at their life habits. They looked at their occupational habits. They looked at their diets, if they smoked, if they drank, if they did drink, how much, what their diet looked like. Did they exercise? Did they even exercise as a matter of, their occupation? If they were manual laborers and they were working hard that way, they monitored all that stuff. And it's through these cohort studies that they actually identified over a very long period of time that there wasn't just an association between smoking and lung cancer, but that association was very strong. Case control, case series, case studies. A case study is a single case detailing analysis of a single subject. A case series is looking at analysis of several subjects. Case control is when you do a case series, but then you compare them to control, cases that did not get the intervention. And expert opinion is just what it sounds like. It's just expert opinion. It's at the lowest end of the hierarchy, which I'll show you in a minute. But the hierarchy is not absolute. If the experts in the respiratory world are, Dr. Jamie Stoller and Neil McIntyre and Dean Hess, then it would probably boost that expert opinion to probably the middle of the pack. The sole purpose of this slide is just to use an image to depict the hierarchy that I just spoke of. So I basically described systematic review, randomized controlled trials, etc. And I described them in the order, if you will, of rigor. Again, with systematic reviews, in this depiction being at the apex of this pyramid. Secondarily is randomized controlled trials, working all the way down to expert opinions. Again, the caveat to expert opinion, even though it's shown here as being at the bottom of this hierarchy, it depends who your experts are. And some forms of expert opinion can actually bear a pretty fair amount of weight if, again, your experts are also the individuals that are conducting and working with some of the randomized control trials and producing some of the systematic reviews. So the hierarchy is important, but it's not absolute. So only second to the systematic reviews and meta-analyses are the randomized controlled trials. So as a single study, randomized controlled trials, RCTs, are the gold standard. Again, to just review, randomization is really, how do you determine whether or not your subjects are in the experimental group or that receiving the intervention being examined in the research trial, or the receiving a placebo? They're randomized. And it's essentially you flip a coin, heads they go to the control group, tails they go to the experimental group, or vice versa. In some cases, believe it or not, there is the flip of the coin, but a lot of this is done today, digitally, so the equivalent of flipping a coin. Controlled, again, you're comparing an experimental group, often one experimental group, but there can actually be more than one, to a control group or control arm. Blinding, I referred to earlier on, and I kind of inferred adequately powered. I didn't describe it, but I did talk about p-value. Okay, again, that 0.05 or 5% or less chance that the results are arbitrary or by chance. Okay, one of the ways that you can enhance the p-value is ensuring that your study is adequately powered. And often that is related to, do you have enough subjects to demonstrate an effect or lack thereof? And the effect would be, does CPAP, is it an effective treatment for individuals who have, who've been diagnosed with obstructive sleep apnea? And again, there's tests that you can do in advance. Researchers will tell you, you can do what's called a priori power testing to help ensure, to guide the research to say, how many subjects do you need, given all these variables, to have a project that's adequately powered and have your p-value be 0.05 or less. And as I alluded to earlier, the categories of research we're going to examine in sleep medicine relate to physiology, diagnostics, treatment, adherence, cost considerations. Now, when I discuss these research trials, I don't give you the full what's called citation, okay? What I'm doing is I actually list the primary author and then parenthetically following it, the year it was published. And so you should be able to search PubMed or Medline, put the particular first author in, et al. Just means, and other authors, other researchers, other authors, and the year, and you should come up with the actual study to which I'm referring, or, if Katamara, if he had published more than one study. You'll see, two or three. Often it's one study that in the study to which I'm referring. So again, this particular one focuses on physiology. I've listed, I'm not going to read these slides to you, but I do list the aim, the methods that were used, and the primary results. Most significantly, though, I will describe the conclusion. So the aim of this particular study was to assess the relationship between body composition and then these objective sleep parameters, male versus female athletes. The body composition was 17 male, 19 female. The results the male athletes studied had more muscle mass and less fat, not surprisingly so. However, the male athletes had lower sleep efficiency, okay, longer sleep onset latency, higher arousal index, and other similar measures. And it was therefore concluded that compared to female athletes, male athletes, kind of ironically, just in general, if you think athletes in general would have, if they're doing all this exercise, they would have better, if you will, quality of sleep. In this case, comparing the males and the females, male athletes, greater muscle volume appeared to have inferior objective sleep quality. It's implying that sleep architecture may be related to muscle volume. Again, they're inferring that last finding. This study done by Meltzer and others published in 2020, it sought to examine the impact of sleep duration on asthma in adolescents. 54 adolescents with asthma, they give you the age 12 to 17, etc., including 5 nights. They looked at 5 nights of short sleep, okay, and that was time in bed was 6.5 hours, and 5 hours of long sleep opportunity, so 9.5 hours. And they looked at primary outcomes, lung function, the impact scale, so really the quality of life, and markers of inflammation. And they determined that the short sleep group had worse morning FEV1. And again, I'm just putting this in here. The p-value here is not 0.06, it's 0.006, okay? So it's a 0.6%. It's not a 6%. So that's a good p-value. It's a very low p-value. It really says that there was well less than a 1% chance that these results were by chance. Worse symptoms, so albuterol use was higher. This p-value was just less than 0.05, okay, so a 5%, and asthma showed a trend towards greater negative impact on daily life. That was a 0.07, so that's a little bit north of that threshold. It was therefore concluded that an insufficient sleep opportunity negatively impacts objective and subjective daily symptoms of asthma in adolescents. A third study, published by Combertaldi and others in 2021, also related to physiology. And Combertaldi and others, they sought to explore the impact of social media use on sleep disturbance, also in adolescents. They tested, the effects of 30 minutes of social media use on arousal and subsequent sleep in the sleep laboratory. 32 healthy young volunteers. The results revealed that 30 minutes of social media use immediately before sleep did not significantly increase arousal. Did neither disturb nor the objective nor the subjective measures of sleep. The conclusion, and this was a little bit counterintuitive to what I would have guessed, and that's what it would have been a guess, that social media use before sleep, controlling for the effects of blue light, so that's eliminating that, had little effect on bedtime arousal and sleep quality than what was previously expected. And I, again, would have been one of those individuals that would have previously expected otherwise. Now we're shifting from physiology to diagnostics, and there is a relationship between physiology and diagnostics, but I aim to just try to make the distinction here. So this one published by D. Goddard in 2021, the aim was using unobtrusive monitoring of sleep and sleep disorders in children presents challenges. Okay, they accepted that. They used the ultra wideband radar to measure sleep in children. The methods were 32 children aged 2 months to 14 years. scheduled to undergo a clinical sleep study or polysomnogram participated. During the polysomnography, the children's body movements and breathing rate were measured using this form of ultra wideband radar. And the results were that although the current performance is not sufficient for clinical use yet at this time, this form of radar is a promising method for non-contact sleep analysis in children. So again, more to come on this. It needs to be studied in more detail, but it's showing some promise down the road. Also in the area of diagnostic, Torstensen and others published a piece in 2021. The aim is multiple aims, but the aims was really to look at the ability of actigraphy to quantify sleep continuity measures in comparison with polysomnography in patients with hypersomnolence. Okay. And just FYI, so actigraphy is a type of wearable sleep test that tracks your movements. So you can, in a similar way, some of the, not just the eye watches, but the devices that individuals can wear often on their wrists can do a lot of this particular tracking as well. And really looking at a device, something along those lines, to analyze when you're asleep and when you're awake. All right, so this actigraphy. So the second aim was whether actigraphy can distinguish patients with hypersomnolence from patients with narcolepsy type 1. So really a subtle difference there. Again, from individuals that have hypersomnolence versus narcolepsy. Narcolepsy is really a disorder where it's not so much an inability to move air. It's just that the individual will just fall asleep midstream. They could be mid-sentence. You could be sitting across the lunch table with them. You're talking about a topic, and then the next minute they're actually asleep. And that is that's a neuro issue. So it's something with the neurophysiology that's off. Well, even though this study is not a physiology study, it really is looking at that group and looking to help try to diagnose the difference between hypersomnolence and narcolepsy. The results, I'm skipping ahead to the results, is that the actigraphy quantified several sleep continuity measures consistent with the polysomnogram. And it therefore was concluded that actigraphy is an adequate tool for establishing the amount of night sleep and supports the differential diagnosis of patients with hypersomnolence versus narcolepsy. We're now transitioning to looking at complementary and alternative treatments. Okay. And this piece was by Chen, published in 2021. The aim was to conduct a systematic review and meta-analysis. So that's really what I was describing earlier. That's at the apex of the research hierarchy. The design, again, systematic review and meta-analysis. The measurement's primary sleep outcome was Pittsburgh Sleep Quality Index. It's a validated tool that's out there. The results, 5 randomized controlled trials were included. Older adults who listened to music experienced significantly better sleep quality than those who did not. By the way, we're not talking about listen to heavy metal before you go to sleep. We're talking about music that is more associated with a calming, you might want to call it elevator type music, but just a calming effect on individuals. So music therapy, was concluded, is a safe and easy to administer treatment modality and can effectively improve sleep quality among older adults, particularly those listening to more, if you will, sedative type music. So more on treatment, but really focusing on that subcategory of treatment of complementary and alternative. Okay, this particular study examined the effectiveness of auricular acupuncture. So that's really has to do with the ear in reducing the symptoms of sleep disorders and anxiety. I mean, anxiety is obviously a different disorder, but anxiety certainly can contribute to sleep disorders. This was a non-randomized, so it was not, it's kind of in the middle of the pack. It was non-randomized clinical trial with, I'm going to use the abbreviation AA, was administered to patients who had one of 3 sleep disorders. And it was concluded that this form of therapy was effective in reducing sleep disorder symptoms, and their data from the study suggests that some relief of symptoms of anxiety can also be achieved. This study by Ong published in 2020, was also in the subdiscipline of complementary and alternative treatment. And it looked basically at the mindfulness, so meditation interventions for insomnia and sleep disturbances. It was a systematic review of the literature, so they looked at the studies that were done in this area. They eliminated the weaker studies, included and combined the results of the stronger ones. And it was found that collectively there's a general support for the effectiveness of this form of meditation on self-reported patient outcomes. The quality of studies varies, and the findings on objective measures are equivocal. Okay, equivocal means the jury is out. Okay, that you really got to look at that. The people said that they felt better, but when you actually looked at using validated instruments to examine objective measures, the results were not conclusive. They were pretty much equivocal. Those that actually had got them, that did the meditation, and ones that did not, they were pretty close together. And it was also concluded that further research is needed to examine biological, correlates associated with this, this form of meditation, and whether the timing matters, and things along those lines. Who's likely to benefit, and the types of sleep disturbances that may or may not be more effectively treated with this form of meditation needs to be further examined. Now we're still in the area of treatment, but in this particular one, we're looking at nutrition. And we could argue that maybe some forms of nutrition fall under the umbrella of complementary and alternative. I've selected to actually separate it out, if you will. So again, this particular piece published in 2020, it sought to explore the role of nutritional supplements, not one nutritional supplement, but several different ones. It was a systematic review of the literature, so again, higher in the hierarchy of the rigor of research, the types of research. The results or conclusions that nutrition can profoundly affect hormones and inflammatory status, which directly or indirectly contribute to insomnia. They looked at vitamin D, so ensuring that individuals have adequate vitamin D. They're not saying that if you take extra vitamin D, you'll fix something. But if you're vitamin D deficient, it can contribute to the problem. Increased magnesium. And by the way, magnesium is not just important in certain, in the action potential of the heart, but it's also can be a potent bronchodilator. But in this particular case, it is determined that magnesium can help promote sleep. Careful with the intake of magnesium, because it can also contribute to things like diarrhea. So, if a person falls asleep, but they could have other problems in the course of the night. So, and then try 5-HTP as a precursor to the hormone serotonin. So it's one of the, if you will, constituents of serotonin, and serotonin is one of those neurotransmitters that helps promote calmness and sleep. And we get into things like chamomile tea. That may sound like an old wives' tale, but there seems like there's some linkage there. Almonds. I'm a huge fan of almonds. I really absolutely love them, but among the best natural home remedies for sleep apnea. It's really more for sleep disorders overall. Small ingredient can basically supply the body with a high amount of magnesium that enables the muscles to relax more. Turmeric it has anti-inflammatory properties as well, and because of that, for individuals that have certain respiratory disorders, it can be effective. One of the mechanisms that is effective in reducing the inflammation and therefore promoting sleep. Also in the area of treatment was this study by June, published in 2021, with an aim to evaluate current non-pharmacological sleep interventions for critically ill patients in the intensive care units, and to also provide subsequent recommendations based on the results. A systematic review of the literature that was published in this area from 2012 to 2020. The results determined that interventions involved earplugs, eye masks, white noise, music and aromatherapy, massage, etc., light intensity. It also looked at non-pharmacological interventions, and it determined that they all tended to improve sleep quality. Now, the challenge in the ICU, as many of you are aware, is that sleep quality tends to really be very lackluster. So anything that can contribute to enhancing that poor baseline is viewed as a big plus, particularly because we're looking at patients that are already critically ill. And this study concluded that non-pharmacological sleep interventions can have a positive influence on sleep quality in critically ill patients. But more research is needed to determine their effectiveness, determine perhaps the interaction when you're actually combining things like earplugs and eye masks and white noise, et cetera, and which ones to combine, which ones may have more effect, which ones may actually have little to no effect at all. This study focused on, if you will, pharmacologic or medication treatments. And more specifically, the aim of the article is to compare the effect of hypnotics, category of hypnotic medications, and the antidepressant trazodone on sleep. It's also a systematic review and ended up including 11 studies. Again, these were these stronger studies to which I referred. The results pointed to trazodone being determined to be a very effective treatment for sleep maintenance, insomnia, especially in patients with comorbid mental disorders, were treated with activating antidepressants. So hypnotics and trazodone have the opposite effect on deep sleep. And it was therefore concluded that trazodone increases the duration and quality of deep sleep. In contrast, hypnotics decrease slow wave activity, a biomarker of deep sleep, and therefore can have an inhibitory effect on deep sleep. So this study is one that's near and dear to my heart. It has to do with upper airway stimulation for obstructive sleep apnea. And it's near and dear to my heart because in about 2015 or 16, I ended up having to revise a chapter on sleep out of one of my textbooks. I had somebody recruited and they had personal situation. They had to back out of the responsibility. The deadline was getting close. So I teamed up with another colleague of mine, and we ended up updating the chapter ourselves. And I had to do an extensive review of the literature, and I came across this Strollo piece that was published in 2014. And let's talk about it briefly. So the method was a multi-center prospective, single group cohort design. And they looked at this surgically implanted upper airway stimulator, 126 patients. Let me cut to the chase. The results or the conclusion, it was uncontrolled. So it wasn't like they compared the one group that got the upper airway stimulation to another group that didn't. This was the initial study. So they just looked at the 126 that got the intervention, but they actually looked at improvements in their results. So they determined that the upper airway stimulation led to significant improvement in their apnea hypopnea scores and subjective measures, including quality of life. Now, a few years later, Seuss and others in 2018, they looked at a prospective multi-center cohort study of patients with moderate to severe OSA. And basically what they did was they, if you will, supported the results that Strollo initially came up with in 2014. And that patients with moderate to severe OSA and body mass indices less than 32, basically a BMI less than 32, that they determined that hypoglossal, which is upper airway stimulation, nerve stimulation, can provide significant improvement in sleep-related quality of life outcomes measures. And it also included not just an immediate, weeks long, but it did a 2-year follow-up and said that these benefits were maintained over a 2-year period. And this is just a graphical depiction of the upper airway stimulator for OSA. On the, if you will, left-hand side of the presentation, it shows you the overall setup and shows you the actual, if you will, remote control. So, you have a generator, you have a sensing lead that's actually sensing diaphragmatic activity. So diaphragm contracts, it drops down at the beginning of the breathing cycle. And then the signal would be sent via the stimulation lead to the upper airway, sending that signal so those muscles would contract, opening the airway. And just a different, similar depiction, but showing it a slightly different way is on the right-hand side there as well. So let's examine CPAP adherence. It's been an ongoing problem. The title of this presentation is the latest in sleep medicine research. And I'm presenting some studies that have been published in the past 5 years or so, including this one. But the key really is that this is not a new problem, that there's been challenges with adherence to CPAP or BiPAP therapies for decades. And it was proven 20 years ago, and it's being reaffirmed more recently. This particular study by Rottenberg, published 2016, they're looking at CPAP, known to have problems with adherence. Many patients eventually abandon the device. And I will tell you this, it's bifurcated. So you have obviously ones that are compliant right away. They're actually in the minority, but you have ones who, over a relatively short period of days or weeks can eventually become compliant, okay, with, proper protocol, proper follow-up, proper coaching, things along those lines. But they also find that after 2 to 3 years of adherence, that some of those individuals also drop off, that their adherence can drop off, perhaps because it's almost like somebody who's been taking their psych medications, they're feeling a lot better, they feel like they don't need them anymore, they stop taking them and the wheels fall off the wagon. So similar kind of bifurcated early on adherence issues, and then, down the road, 2-3 years down the road as well. So this study really looked at, it was a systematic review of the literature, and it looked at, the secular trends in CPAP adherence over, long-term use to see if there's been some meaningful improvements or not. And based on the combined results of 82 papers over a 20-year period, the overall CPAP non-adherence, based on 7 hours of night per sleep, was 34% non-adherence. So over a third of your patients. I will tell you, there's other studies out there that say that non-compliance rate is higher than 34 or whatever percent as well. It's high. Even if you said, well, it's only 25%, it's still a big number. But again, there's great variability. The conclusions were the rate of CPAP adherence remains persistently, low over 20 years worth of data. No clinically significant improvement in CPAP adherence was seen in recent years, despite a lot of interventions. This low rate of adherence is problematic, calls into question the concept of CPAP as a gold standard. So when you really look at this issue of non-compliance in these patients, it's not just that they're sleepier, that their quality of life isn't as good, is that there's all these comorbid conditions that exist that are really, really problematic. Worsening diabetes, worsening, a heart disease, things like at risk for hypertension and stroke, and other things as well. And frankly, individuals that have obstructive sleep apnea don't just have a worse quality of life. They tend to use health resources disproportionately, much more than the general population. I know that sounds very insensitive and very mercantile utilitarian, but it's the fact of the matter. Their quality of life, subjective quality of life, is worse. They have more conditions. They're sicker, and they place a greater burden, if you will, on our healthcare resources. So Shapiro also studied CPAP adherence, and we'll skip down to the results in the interest of time. Adherence rates dropped to 54%, 54.5% at 3 years. And this was where they really looked at, it was higher than that, but you had this period of time, 2 to 3 years out, where strangely adherence tended to drop off. Beliefs and attitudes were significant factors associated with adherence. Life satisfaction was significantly higher at present compared to before wearing, the CPAP. So they determined those things as well. But the conclusions look like this. The authors recommend intervention with a focus on apnea beliefs, CPAP attitudes, long-term support to promote CPAP adherence. Focusing on CPAP attitude and beliefs enhanced support early in the obstructive sleep apnea treatment trajectory, which may promote also this longer term adherence as well. But again, the key points, just like we're doing with our COPD patients on, before their discharge and on discharge and following up with them, it's education, following up, determining if there's barriers, if the individual's claustrophobic, if the individual has nasal dryness, whatever, introducing a humidifier, introducing this coaching, get them involved in group support groups and things along those lines. All those things collectively can make a difference. And again, this piece by Shapiro kind of points in that direction as well. Now, Patel took a look at CPAP adherence by trying to, if you will, quantify what groups tend to be more compliant, age, gender, things along those lines, versus, groups that are less compliant, all right? And they really looked at it as a retrospective use of telemonitoring data, okay? But they actually looked at, the U.S. Medicare, Centers for Medicare and Medicaid Services, CMS, and they looked at a lot of, the patients that were within their database. Age range from 18 to 90, and looking at years 2015 to 2018. Overall adherence by U.S. Centers for Medicare and Medicaid Services criteria was 72.6%, almost 73%. Dramatically varied by age and gender. Ranged from 51 and change percent in the 18 to 30-year-old women to a high of almost 81% in 71 to 80-year-old men. Patterns of use first 90 days demonstrated that younger age groups had a peak CPAP use by the second night. But they had a subsequent, if you will, decay or decline in use, which was greatest among young women, 18 to 30 years old. So they're compliant on day 2, but their longer term compliance drops off dramatically, particularly in those younger females. In contrast, older patients steadily increase use, and then they have much, slower decays over a period of time. They concluded that CPAP adherence varies substantially by demographics. The pattern of use over the first 90 days also varies substantially by age and gender, and further research is needed to further explore these trends. So when I was reviewing the literature to prepare this presentation, I came across a lot of studies that were done by Warren Wickwire and his group. This particular one was published in 2021. And it really looked at kind of that intersection of adherence and outcomes. So adherence, and then the clinical implications of non-compliance with the therapy. So the aims, again, examining the impact of adherence, with CPAP therapy on risk for cardiovascular events, and looking on the impact that it has, that if you also factor in things like race, gender, and socioeconomic status. So this was a retrospective study. So what they did is they looked back, at these over 5,000 Medicare beneficiaries with obstructive sleep apnea and extracted the data from them. And the results were that there were about 1,678, 33% demonstrated new cardiovascular events. So that's a much, much higher percentage than the general population. CPAP adherence was associated with reduced risk of new cardiovascular events. So if individuals had, a cardiovascular event, a heart attack, and then they became compliant with CPAP therapy, their risk dropped dramatically from that, 33% dropped way down. There was no significant difference in the protective effects of CPAP based on race, gender, socioeconomic status. And they concluded from this study, CPAP adherence was associated with greater reduced risk for cardiovascular events. The risk reduction was consistent across basically all of those subgroups of race, gender, and socioeconomic group. So I took a, if you will, a screenshot of an article, and I really don't typically do this, just to be completely transparent on this. I don't expect you to read the words in this. That's the good news, okay? But I, just kind of like wanted to put it in there so that if those of you who are interested in reading more, you'll kind of know it when you see it, because at least the first page of it is basically cut and paste here. But this was done by Kawala and others, published in 2021, and they looked at CBT use. So basically and a constituent substance of cannabis, and they determined it did not enhance positive airway pressure adherence. So I'm cutting right to the chase on this. I'm not going to spend a lot of time on it. If those of you want to read more on it, you can just take that, Koala 2021. You can put in CBT and PAP adherence, and you'll get a hit on it. You can read the entire article. But this particular one found that it did not enhance PAP adherence. This piece published by Pachito in 2022 looked to synthesize the findings. So really, synthesize is you go through them, combine if you will, the stronger results, and come up with conclusions or inferences of economic evaluations investigating the cost effectiveness of CPAP for treating obstructive sleep apnea. It was a scoping review, took a look at several synthesized databases, including Medline and others. The results, 34 studies were included. 3 concluded that CPAP is less costly and more effective when compared to usual care. Okay. Most studies indicated that CPAP is associated with better health outcomes, but at higher prices. 3 studies assessed the effects of organizing CPAP therapy in primary care, which was cost effective, or could at least result in cost savings. And this study concluded that compared to usual care, CPAP is cost effective after the 2nd year of treatment when indicated for moderate to severe OSA. CPAP therapy may be even more cost effective by using different strategies of organizing care, and more specifically that involving the primary care physician in ordering the sleep study rather than a referral to a sleep specialist or a pulmonologist in doing so. So in this study from 2021, Sullivan sought to understand sleep medicine educational exposure among parent specialties, sleep medicine fellowships. So they actually targeted respondents, program directors of family medicine, and other particular specialties. The goal in lay terms was, are the residents getting exposure? Are they getting not just the training, but the knowledge to make that initial referral for a sleep study? Okay. And the results were that a total of 1,228 programs were contacted, and about almost just under 500 responses were received, for a response rate of about 39%. They looked at pulmonary critical care and neurology, reported the highest percentage of sleep medicine rotation, and an option for house staff. So just looking at, not surprisingly, they actually got the highest. Teaching format was a mixture of didactic, so that's classroom, sleep center, laboratory exposure, and case reports. Looking at, either listening to presentations or having the actual participants present. Few programs reported trainees subsequently pursued sleep medicine fellowships. So the conclusions were that there's a wide variability in overall low exposure to sleep medicine education among physician education programs in the United States. It's a disappointing finding. So coming down the home stretch, let's take a look at some key take-home points. So there's been a lot of research that's been done through the years and in the past 3 to 5 years in sleep medicine, not surprisingly so. The research has helped shape this aspect of healthcare practice and continues to do so. Some research has more scientific merit than others, so it's not all equal. And understanding how to identify, evaluate, and integrate strong research is an important skill set. The research is changing all the time based on new discoveries, so it's important to keep up to date. So I want to conclude the presentation with sharing with you some selected references. And the first one I have here is Spriggs, Essentials of Polysomnography. So Spriggs would be to the sleep clinician, like Egan's Fundamentals of Respiratory Care would be to respiratory care. So Egan's Fundamentals of Respiratory Care is one of the 3 textbooks that I co-edit. And it's really a foundational textbook for respiratory therapy education. So if there's any nurses or sleep technologists, I'm sure there's sleep technologists in our audience. Spriggs is a big deal, and it should be a go-to resource. Egan's, I've listed it here as well because we have a nice chapter on sleep medicine that Jamie Stoller at the Cleveland Clinic, one of my colleagues on Egan's, recruited, and it's a pretty solid chapter. My clinical assessment and respiratory care textbook also has a chapter dedicated to that as well. And then I've listed a number of articles, and I did a little bit of cherry picking of some of the key articles from those that I presented on today. With that, I want to thank you all for participating in today's lecture. We hope that you learned something, and it may be one of those things that you already learned, but maybe passage of time, etc. You didn't really use it, and maybe you forgot it, or is information that maybe you just reinforced information that you learned and you didn't forget. And we certainly hope that you come back to us and join us for other lectures in the future. Again, thank you, and have a wonderful day. Bye.